I will call upon Dr. Tushar Madke, consultant hepatologist and liver transplant physician in Midas Hospital. He will be speaking on interpretation of abnormal LFTs. For this, I would like to call chairpersons Dr. Nikhil Balanke, Dr. Shubhankar Godbole, and Dr. Rahul Devtare. Dr. Dhaneshwar Katarmal, if he is present, please join as chairperson. Huh? Dr. Dhaneshwar Katarmal, you are invited to be as chairperson, please.
Good morning. I would like to welcome Dr. Tushar Madke. Dr. Tushar Madke is a hepatologist with us. He has done his DM from ILBS Delhi, which is a very reputed institute. Very keen interest in ACLF and ALF. I would like to invite Dr. Tushar. Please, over to you. Please start.
Thank you, Dr. Shubhankar, for such a warm welcome. So, my topic for today is the interpretation of abnormal LFT pattern. So, first thing that I want to tell is it is impossible for me. So actually, it is impossible for me to cover whole interpretation of the whole LFT within this 15 minutes. So what I'm going to do is I'll take you through some clinical cases that we usually see in our routine practice, and then I will try to unravel the thought process what we apply behind the diagnosis through these LFTs. So first case, we have this 32-year-old male who just on a yearly medical checkup found to have a deranged LFT. He's been drinking 3 to 5 beers per week for the last 4 years, no comorbidities, and BMI is around 28. So his LFT, which shows the AST of 119, ALT of 156. He found to have raised triglycerides and LDL-C, grade 2 fatty liver on the ultrasound. So what is your diagnosis? Alcoholic hepatitis. Actually, the answer is mast cell. So it was only 4 to 5 years is not a significant dose of alcohol, and he has BMI of 28 with enzyme elevation. So we usually call them SLE. I'll come to this topic later in my slide. So second, similar case, similar kind of result, but this time he's not taking any alcohol. BMI of 28. But when on pressing upon the history, we found that this another patient, he was taking CAM for weight gain. So now what's your diagnosis? So I'll not take much of time. So our diagnosis is usually DILI. So another third case, so we have this 28-year-old, this time a female, and with the BMI of 31 and comorbidity being hypothyroid. So here what is the most likely diagnosis? Can you be voting for this? It's autoimmune. Well, it still can be mast cell, but it's a good. Through these three cases, what I wanted to highlight here is what thought process you apply before interpreting any LFTs. So no investigation makes sense out of a clinical consensus. Every time, like just what Dr. Dubey and Dr. Patil said, you always have to interpret LFT with keeping in mind the clinical context. In first case, he was obese, had a hypertriglyceridemia, raised LDL, and deranged LFTs, but very moderate or mild alcohol intake. So it was mast cell. Second, he had DILI. Third occasion, she has other autoimmune hepatitis, and if she was female, that's why we kept a diagnosis of autoimmune in the second case, but she can be still mast cell. So we need to investigate it further. Coming to the next case, 32-year-old male again with heavy drinking this time, 50 to 60 grams of alcohol per day for the last 5 years. No comorbidities, BMI of 29. In this also he had this grade 1 fatty liver with AST, ALT of 138 and 65. So would you call this patient alcoholic hepatitis? The answer is no. Similar patient, similar history, but the LFTs are changed this time. His bilirubin is, his bilirubin is 6. Now AST is more than ALT. So what will you call this patient? Now you can call it as alcoholic hepatitis. So with this, in the previous 3 cases, you are seeing the history was different, but the LFT pattern was same. So you have to clinically correlate with the history. In these 2 cases, the history is same, alcohol intake is same, but the LFT pattern is different. In the previous patient, we have no bilirubin rise, moderate elevation of LFT. Second patient, rise in bilirubin, AST more than LFT. So what are we looking here? We are looking at a pattern of LFT with the similar patients. So I want to highlight here is when you call alcoholic hepatitis, because most of the time I am seeing in clinical practice is that just if some patient is drinking alcohol and had deranged LFT, they are usually labeled as alcoholic hepatitis, but this is not the case. So patient should have a jaundice. The level of jaundice should be, the bilirubin should be more than 3 to call him as a jaundice. The AST-ALT pattern, the AST-ALT ratio should be more than 1.5 and both of the values should be less than 400. So just alcohol intake and deranged LFT we do not call. And why this differentiation is important? Because if you see the patient who had just taking alcohol and has steatosis because of alcohol intake, their prognosis is much better as compared to the alcoholic hepatitis patients. So that's why making a clinical diagnosis on the basis of history and the clinical pattern of LFT is important. So now just one slide on this steatotic liver disease. Now what we are seeing this new term that SLD that was introduced in the last year by SLD. So if patient had any signs of fat in his liver on the basis of imaging or biopsy, what we first look at the cardiometabolic criteria. So these are 5 cardiometabolic criteria that we usually look at. If we have any one criteria out of this, then we term this patient as a MASLD. If we don't have any cardiometabolic criteria but has a fat in the liver, then we look for the other causes of fat in the liver, such as alcohol, the drugs, especially the anabolic steroids, your antiepileptic drugs, your hepatitis C can cause steatosis, or in the rare cases or in children we can see for the monogenic disorders. So this is the spectrum of this steatotic liver disease. I will not go into detail of that. Now coming back to the next case third, a 28-year-old male student living in a hostel. He has anorexia, nausea, vomiting since for the 5 days, low-grade fever, pain in upper abdomen, and he was taking acetaminophen tablet around 2.5 gram per day for the pain. On lab investigation, you can see he has AST-ALT elevation more than 10 times with slight rise in bilirubin. INR was 1.5, platelets in the normal range. Enlarged liver with the pericholecystic edema. Now why I wanted to highlight this is, I have seen many a patient just for a viral hepatitis getting their cholecystectomies done outside because they have this gallbladder edema. So I just wanted to highlight that this is a normal finding in any viral hepatitis patient. This is due to the congestion of the liver and there is extravasation of fluid outside the gallbladder. So don't mistake it for any cholecystitis. So even you can take this sign as a diagnostic marker. If you don't get any hepatitis serology positive, you have raised enzyme which are in the range of viral hepatitis and you are getting this pericholecystic edema, then you can diagnose this patient as a viral hepatitis. So this case, it was viral hepatitis. What we did, we further evaluated this patient for the next viral serology and the fever serology, and all was negative. So what will you do next in this patient? Good. So always we do the serial LFT monitoring. If the patient's enzymes are improving, LFT is improving, and you don't get any cause for the deranged LFT, then we don't have to worry. The patient will improve. But if they don't, then we can consider doing an extended liver panel. What we did here, what you see, this was the course of the disease in our patient. So here the bilirubin has started to decrease, AST-LT has started to decrease, and so this was, if on the face of it, next. Many slide. No, just I wanted to highlight here is, you can see the LFT is improving, your AST-LTs are going down. So you can see just face, if you look at only LFT, you can see that the patient is improving. But here again I want to emphasize that you have to look at the clinical pattern. At day 5, our patient has become drowsy. He had got asterexis. So now how do you interpret this improvement in LFT? So now what this LFT suggests, that the liver has getting severely necrosed. There is no liver left to produce the enzyme. So that's why it is always said that you should always make a clinical examination history relevant to the liver enzyme. So what will you check next? So you check INR ammonia. In our patient it was 3.6 and ammonia was 221. So patient need an immediate liver transplant. He don't have any liver left to produce an enzyme. We just need a further evaluation just to look whether we have any treatable cause like Wilson's, autoimmune or hepatitis B. It was all negative. So what do we call this type of hepatitis? So previously, as the years passed, all the new viruses were getting discovered. So previously this terminology was non-A, non-B, non-A, B, C, or non-A, non-E. Then they used to call it as a seronegative hepatitis, but this term was specifically kept for the autoimmune or immune-related liver injury. Now the preferred term in the literature is the indeterminate hepatitis, when all the pathological mechanism for liver injury is not there. So what are the causes? The viruses, unrecognized autoimmune, unrecognized paracetamol overdose, idiosyncratic drug, or a metabolic or a genetic disorder. So causes. What are the causes? The most common being the HSV, CMV, or the parvovirus. This can occur in immune-compromised or in immunocompetent individuals also. Others being the seronegative autoimmune disease, you usually suspect when there is a female. The HLH syndrome, their urea cycle disorder in children, or the idiosyncratic reaction, or you can when you press upon the history, or you can take into account the profession of the patient and can check for the heavy metal level. So sometimes you have to check, if we are not sure about paracetamol overdose, then we have to check for the paracetamol addict. If there are more than one, then it can be the cause. I'll skip this question. So coming to the next case, a 72-year-old male, long-standing alcoholic cardiomyopathy with left ventricular failure. He was admitted with worsening dyspnea, fatigue, peripheral edema, orthopnea, decreased urine output for the past days, but no chest pain. He had hypertension, tachycardia, increased heart rate, hypoxia, increased respiratory hypoxia, raised JVP, pedal edema, and bilateral clackets. His enzymes were in 10,000s, which with our good ICU team we were able to manage him, and now his enzymes have been reduced. So what's the diagnosis here? So I'll be in the interest of time, I'll just skip it. So diagnosis is ischemic hepatitis. The causes of massive transaminitis are the ischemic hepatitis, the hepatic hepatitis, heavy metal induced poisoning, the paracetamol poisoning, acute Budd-Chiari syndrome, hepatic artery ligation. So these are the causes you should keep in mind. Next case, a 23-year-old male applying for a police constable job. He had an enzyme elevation 410 and ALT of 209. These were discovered during the routine testing. So all the other liver tests were normal. So he used to consume around 20 grams of alcohol per day. On later testing, even after abstinence, his enzymes were rising. So further serology was done, which was also negative. So on the pressing upon his history, what we noticed that he was training intensely, and after his training session, he used to have muscle ache. So what we found that his CPK was raised and LDH was raised. So this looks like a cause of non-hepatic elevation of a liver enzyme. So what are these non-hepatic causes? So we usually see celiac diseases most commonly in our practice, and they do respond to the gluten-free diet and their LFTs improves. The strenuous exercises, muscle diseases, and post-conversion you can have a rise in liver enzyme level. So what in this study what they found that they this was the study on 16 patients, when they do a strenuous exercise there is an elevation of LFT which remain elevated for the over next 7 days. So the author concluded that prior to any clinical studies or during any studies there should be a relevant restriction to the heavy muscular exercise. So how this muscle-related transaminitis can be interpreted? If you see in extreme case of exercise, the AST is more than ALT. The AST-ALT ratio is usually 5:1, and while all the liver functions being normal, in muscle diseases such as polymyositis, there is a moderate elevation of enzyme, and the AST-ALT ratio is usually 1.2 to 1.5. With normal levels of other liver functions. So in any case where there is an elevated ALT level, in the absence of liver disease, you can consider a muscle injury, and which can be confirmed with the creatine kinase and the LDH level. So this is a textbook algorithm to diagnose whatever the common causes that we usually face during our clinical practice. So when you consider liver biopsy, so you do not consider liver biopsy just for if there is if the patient have a deranged LFT and you don't find a cause. You have to justify the liver biopsy. Like in Wilson's disease, you have a borderline, let's say you have borderline ceruloplasmin, borderline 24-hour urinary copper. Then just to confirm this diagnosis, you do biopsy, and in biopsy you find that the pattern is similar to what we see in the Wilson disease, then you confirm the diagnosis. In case of HBV, we do biopsy to see whether there is inflammation or not, fibrosis or not, and on the basis of that we start treatment. In alcoholic hepatitis, we do biopsy to check the prognosis. If the AHHS score is more than 7, then we communicate that this patient has a poor prognosis. And third, the autoimmune hepatitis we do for diagnosis as well as monitoring therapy. So biopsy can never tell you 100% diagnosis. It just shows you the pattern of injury, hepatocellular pattern, infiltrative pattern. So you have to correlate it with clinically, you have to justify why are you doing the biopsy, and then proceed forward accordingly. So in summary, always keep the clinical context in mind while interpreting the LFT. Then analyze the pattern of LFT. There is a different pattern for each disease. Most of you are aware of these patterns. Normal, when the liver is normal, you can consider for the extrahepatic causes, and liver biopsy should be considered only in the relevant clinical context. So it is impossible for me to cover all the other topics, including cholestasis, bilirubin, albumin level interpretation. So thank you.
Tushar have covered most of the how to approach to the patient.
Yes.
After taking detailed history as per our senior have talked
Yes.
detailed history, and this lab investigation is more supportive.
Yes, sir.
As ultrasound also is more supportive.
More supportive.
Additional to this one, we do the fibroscan
Yes.
is more effective. At least we can reach to the diagnosis.
Yes.
And you have given very detailed, nice history-wise scenario, as well as the how to approach to the autoimmune disorder also, and drugs-induced hepatitis and viral hepatitis. Very nice.
I'll just make a brief comment that whenever you have fibroscan is done with the idea to know about the fibrosis in the liver, whether the liver is stiff, hard. And if you have an enzyme elevation which is more than 10 times, as in viral hepatitis, then your liver will be stiff. It will give you more
False impression.
false impression. So, I mean, the fibroscan has to be done in a clinical context where your liver enzymes are not more than 5 to 10 times. Bilirubin should be less than 5 times. Otherwise, all patients with viral hepatitis, congestive hepatomegaly, if you have taken food and the blood supply of the liver increases, that can give rise to false increase in the thickness of stiffness of the liver. So that is very important when you order for fibroscan.
Yes.
So there is enzyme 5-nucleotidase. So
Yeah.
how could it help in day-to-day clinical
It's
practice?
similar to GGT. Most of the centers do not use 5-nucleotidase. It will just tell you whether the enzyme elevation, that is alkaline phosphatase elevation, whether it is due to liver or other causes such as bone-related disorder. So it will help in differentiating that. If there is no further question, I think.
Thank you, Dr. Tushar.
Thank you.
We will close the
Thank you, Dr. Tushar, for wonderful session.